Welcome back, coders! Grab your manuals and get ready, because today we're tackling a massive milestone in our boot camp. Welcome to part 41 of our Seek, Share, and Subscribe to Decode Healthcare with Harshal. Let's get to it. Okay, so here's our roadmap for today's high-yield explainer. We're going to cover Level 1 versus Level 2, break down the HCPCS alphabetic code ranges, look at essential Level 2 modifiers, tackle Medicare ABN modifiers, dive into DME POS and medical necessity, and finally wrap it all up with a quick summary and cheat sheet. Let's lay down the foundation. Section 1, Level I versus Level 2. So there's a really fundamental difference you've absolutely got to understand here. HCPCS Level 1, these are just your standard CPT codes. You know, the 5-digit numeric codes maintained by the AMA that describe what the provider actually did, the procedures, the services. But HCPCS Level 2, these are maintained by CMS. They're alphanumeric, starting with a letter from A to V. The key takeaway? Level 1 is the action, but Level 2 is the item. It's what was supplied, dispensed, or used, like medications, wheelchairs, or an ambulance ride. Moving right along to Section 2, HCPCS alphabetic code ranges. Welcome to the alphabet soup. You've got to know these letter families cold. If you mix them up, a claim for a high-tech prosthetic could accidentally get billed as temporary Medicare paperwork, which is a guaranteed denial. So let's use some memory hooks. A is for ambulance and supplies. E is for equipment, specifically durable medical equipment like hospital beds. G codes are CMS temporary clinical codes for Medicare-specific stuff. J is for jabs. These are your injectable, non-oral drugs and chemo. L is for limbs and braces, orthotics and prosthetics. And V is for vision and hearing. Lock those in. Now those J codes, they actually require a little bit of math, and you will for sure be tested on this. Step 1. Read the code descriptor's increment incredibly carefully. Does it say per 1 milligram or per 10 milligrams? Step 2. Convert the total administered dose into units based on that specific increment. And Step 3. Verify your math. If a patient gets 150 milligrams of a drug and the code says per 10 milligrams, you're billing 15 units. Which brings us to a massive exam trap. 1 injection does not automatically equal 1 unit. I repeat, J-code billing is entirely based on the administered dosage, not the physical injection event. Always let that code descriptor be your guide. Let's jump into Section 3, Essential Level 2 Modifiers. Because in HCPCS, just finding the right code is honestly only half the battle. Modifiers are absolutely critical for actually getting these claims paid. You have to apply extreme anatomical specificity. We're talking LT for the left side, RT for the right side. There are specific modifiers for individual fingers, FA through F9, and toes, TA through T9. Even eyelids have E1 through E4. And for ambulances, you've got to map the exact origin and destination using 2-letter combos, like RH means residence to hospital. The first letter is where they started, the second is where they ended up. If you don't map that route perfectly, the claim bounces right back. Okay, Section 4, Medicare ABN modifiers. This is all about who carries the financial liability. Advanced Beneficiary Notices, ABNs, are those forms patients sign acknowledging that Medicare might not pay for a service. What's wild here is how a simple 2-letter modifier dictates exactly who gets left holding the bill. GA means a signed ABN is on file, so the liability shifts to the patient. GX is a voluntary ABN. GY means the service is literally just statutorily excluded by Medicare. And GZ, that means you fully expect a denial, but you didn't get a signed ABN. And here is another huge exam pitfall. Please do not mix up GA and GZ. GA means the ABN exists, which protects the provider. GZ means there's no ABN. In the real world, a single GZ modifier mistake means the provider takes the financial hit, which can literally cost a hospital thousands of dollars. Moving into Section 5, DME POS and medical necessity. That's durable medical equipment, prosthetics, orthotics, and supplies. When you're billing for equipment, you've got to tell the payer the exact status of the item. Is the patient buying it brand new? You'll use modifier NU. Are they just renting it for their recovery? That's RR. What if it's used equipment? You use UE. Sometimes you'll also need the KX modifier to prove that specific medical policy requirements have been met. But listen up, absolutely none of this gets paid without a strict certificate of medical necessity, a CMN, signed by the ordering physician. No CMN, no payment. And just like that, we're already at Section 6 Summary and Cheat Sheet. Let's do a rapid-fire wrap-up. Here is your ultimate HCPCS Level 2 mental checklist for exam day. Keep this locked in your brain. Level 2 is for items and supplies using alphanumeric codes. Memorize those A through V categories. For J codes, always do the dosage math. Nail your anatomical and ambulance route modifiers. Remember that GA means a signed ABN is on file, while GZ means you don't have one. And for DME, track your new versus rental modifiers and always secure that medical necessity documentation. You are officially one step closer to conquering the CPC exam, but ask yourself this. If a single missing GZ modifier can cost a medical practice thousands of dollars, how much weight does a single diagnosis code carry? Are you ready to master the domino effect of ICD-10 CM coding guidelines? In Part 42, we're going to break down conventions, the alphabetic index versus tabular list rules, and combination codes. Keep studying hard, keep that focus sharp, and I'll catch you in the next explainer.